gentlemen, please welcome Professor Azam Bukhari, another bright star of dermatology fraternity. Ladies and gentlemen, since the beginning of civilization, mankind has been encountered a continuous struggle between bugs and drugs. This dynamic interplay between pathogen and the pharmaceutical has presented us with profound challenge. Our next speaker is a very dynamic and multi-talented and inspiring leader in dermatology. He has more than 100 publications to his credit and is currently head of department, Mayo Hospital, and Pro-Vice Chancellor, King Edward Medical University. Please welcome Professor Dr. Ijaz Hussain on stage.
Ladies and gentlemen, Honorable Professor, Sabina Saeed, Professor Azam Bukhari Sahab, Professor Tahir Hamid Ahmed Sahab, Professor Tariq Rashid Sahab, Professor Shahbaz Aman Sahab, and ladies professor. कल परसों वो ladies का Women's Day था, तो ladies women empowerment का day, तो देख सकते हैं कि there majority of females are sitting. First, I must congratulate Professor Dr. Faria sir and Professor Harun Nabi sir for arranging the first symposium on pediatric dermatology. Since वो किसी ने क्या कहा कि जी वो यहाँ नहीं तो यहाँ से निकाले हुए तो हैं. I also happen to serve this institute for 10 months in from 14 to June 15. The topic given assigned to me was fever and the bug versus drug phenomenon. What I understood from this is that the two major causes of rash are fever and rash are either infectious agents or drugs. So how can we differentiate between these two? Fever and rash is a common symptom complex. It is a heterogeneous complex. What do we mean by heterogeneous complex? That they vary in etiology as well as morphology, how they present. And the infections or the conditions may vary from mild self-limiting disease to very serious life-threatening condition. Classically, in 1956, xanthines were prescribed starting from measles, rubella, scarlet fever, and erythema infectiosum, and then erythema subtitum or roseola infectum, and it was found that there is no food diseases with some form of scarlet fever. And the whole exercise is to differentiate whether the condition is benign, should the patient can be managed at home, or does he or she need hospitalization and multidisciplinary approach. Etiologically, there are two main groups: infectious diseases and non-infectious. Different viruses can give rise to fever and rash, bacterial infections, rickettsial infections, and these lists are not complete. They will ever go on increasing, new bugs they will be discovered. And amongst non-infectious diseases, there are two groups. One is collagen vascular diseases, and the second is dry hypersensitive respiratory rashes. How bugs and drugs, they cause the disease. First, there is microbial entry into the body. They multiply, enter into the blood, and then they reach the skin, multiply there, cause the skin lesions, or they release toxins, exotoxins, like we see exfoliating or other toxins which we see in toxic shock syndrome. Or there may be vascular involvement in the form of vasculitis or vascular occlusion, leading to purpura. Drugs, they can give rise to immunological reaction, all types of human gel classification, all types of food reactions can occur from the drugs. Now, morphologically, there are the different patterns. The most common pattern seen in fever with rash is morbilliform or maculopapular erythematous rash, which is classically seen in the measles. Then these erythematous rashes, they further can be divided into localized rash and generalized rash. Like there is erythema, and it is localized to one area, seen in cellulitis, erysipelas, or cellulitis like picture can be seen in various autoinflammatory conditions. And there is long list of maculopapular eruption which arises due to different variants. The latest addition is COVID-19. As I said earlier, that single pathogen, for example, COVID-19, we saw all types of rashes with this with this virus, maculopapular, papular, vesicular, purpuric, even lividoreticulus, like single agent can give rise to different types of rashes. Erythema marginatum. And then there is another type of rash which is seen in the scarlet fever. And this is known as scarlet uniform rash, seen in different diseases like Kawasaki disease, hypovasculitis, toxic shock syndrome. And there was a syndrome, this Kawasaki-like syndrome, describes in children with COVID, which is known as multisystem inflammatory syndrome due to COVID. Then other vesicular bullous rash can be localized, herpes simplex, herpes zoster, and foot-and-mouth disease. And then they can be very life-threatening, this broad spectrum ranging from erythema multiforme on one hand and toxic epidermal necrolysis on the other. Bullous drug eruption like generalized stiff drug eruption can be seen, staphylococcal scarlet skin syndrome, and other infections which can give rise to vesicular rash. Pustular rash, that can be localized or can be generalized. Similarly, purpura. Whenever we see a patient with purpura, a child with purpura, it means that we are dealing with some serious condition. Classical example in generalized is meningococemia. अच्छा जो डर्मा का लिटरेचर है वहाँ पर्परा फल्मिनेंस का जिक्र होता है, लेकिन जो pediatrics का लिटरेचर है वहाँ इतना इसका जिक्र नहीं है जो cause of xanthins है. So I have put this पर्परा फल्मिनेंस in this. Then rickets cell diseases, especially the Western literature, American literature that mentions Rocky Mountain spotted fever, that is a rickets cell disease. तो वो unfortunately हमारे पास तो नहीं है, लेकिन other rickets cell diseases जो इंडिया में हो सकती है, it means they can be possibly seen in our setup. Then it can be necrosis or eschar formation, urticarial rash due to different pathogens. Can be nodular in the form of nodosum, papular, genoticrosis in COVID-19, and other types of like lividoreticularis and J-Phenes, which is seen in COVID issues. Morbilliform rash is classical example of papular erythematous rash seen in measles. There are complex spots. There are maculopapular eruption, usually starts from the face, behind the ears, hairline, from the face, then it goes to neck, trunk and limbs, which is known as cephalocaudal progression. And after say 6 to 7 days, it heals with desquamation and post-inflammatory pigmentation. Scarlet fever rash is seen in the, there is sore throat, mucosal changes, purpuric rash on the junction of hot palate and soft palate, diffuse erythema with micropapules. जैसे sandpaper की तरह हम हाथ फेरें तो there would be rough papules. Here you can see micropapules. This is classical example of scarlet rash. Scarlet uniform eruption seen in scarlet fever, toxic shock syndrome, Kawasaki disease, and many other conditions. This is initially there is white strawberry tongue, then red strawberry tongue, Red strawberry tongue can also be seen in other conditions which present with scarlet uniform eruption. Vesicular rash in a child, this is very seldom. This is staphylococcal scarlet skin syndrome. There are blisters then leading to a superficial exfoliation starting from the flexures, neck area, and then axilla. Erythema nodosum, erythematous tender nodules on the cheeks. Then these are purpuric eruption. You can see angularical lesions seen on the legs, more severe purpuric eruption, DXC, fulminans, and then purpuric papular lesion seen in the Henokshan and Patra, IgA vasculitis seen in the chin. Urticarial lesions can be seen in children when there is fever, urticarial rash with GI symptoms, and we are perhaps dealing with some viral infection. Now, how we diagnose a morbilliform? First, I divided it due to infections, various rash due to infectious etiology, and then a little bit about drugs. Now, the characteristic of the rash from where it started, जैसे आपने देखा कि दो measles और rubella का rash है, it starts from the face and goes down, और disappear भी similar fashion में होता है. ठीक है, जो measles का rash है that slowly appears and disappears, whereas rubella rash है वो within days, के 3 days में सारा rash disappear हो जाता है. Timing of rash and associated symptoms, ये pattern हम separate बात कर चुके हैं. बाज़ दफ़े ऐसा होता है जैसे erythema infectiosum है, the rash starts from the trunk and then goes to other areas. Type of lesion हम बात कर चुके हैं. Associated symptoms and signs ये हम थोड़ा सा एक और slide में बात करेंगे. Pain or pruritus. Severe pruritus is a feature of drug eruption. Viral infection में severe itching immunity. Past medical history. For example, if the patient is having valvular heart disease, the rash can be of infective endocarditis, diabetes, renal failure, trauma, surgery, some sort of immunosuppression. अगर immunosuppression है तो फिर भी rash ज़्यादा chances है disseminated rash. Social history, travel history, hobbies, animal contact, insect exposure, drugs. एक कंटेक्ट अगर फैमिली में किसी और को हुआ है या बच्चा कोई ऐसा हमारे पास आ जाता है कि जिसको स्कूल में ही या शी हैज़ बीन एक्सपोज्ड टू सम पेशेंट, तो वो भी हम इसमें रखेंगे. मेडिकेशन मोर इम्पॉर्टेंट एंड व्हेन वी आर डीलिंग विद ड्रग एडिक्शंस. डिफरेंट एज ग्रुप्स दे शो different etiologies. When we will do examination, we have to look for the lymph nodes, fingertips बहुत सारी जो infectious rashes हैं, then they disappear, they end up with the fingertip exfoliation. Oral mucosa, nails and hair examination. Similarly, examination of the systemic मुख्तलिफ जो हम systems हैं, systemic review के साथ साथ हम examine जरूर करेंगे. Hepatosplenomegaly, heart murmurs, और targeted neurological examination. जब भी एक patient है, especially with purpura, we are bound to do the neurological examination. Fever with acute onset. Fever भी हो सकता है ना कि जैसे intermittent fever हो सकता है, relapsing fever होता है. They differ in the etiologies. Usually acute fever is suggestive of infectious etiologies. In majority of fevers, there are prodromal upper respiratory tract features, and then giant involvement is seen in certain infectious agents like this chikungunya fever, dengue fever, leptospirosis, some autoimmune diseases, involvement of the features. Then there is arthritis of large joints like acute rheumatic fever and Henokshan and Patra. Conjunctivitis is seen in Kawasaki disease, measles, toxic shock syndrome, diarrhea like Vibrio vulnificus, hemolytic uremic syndrome, that is also an emergency. It can end up with this gas gangrene. Then mental changes, meningococcemia, SLE, type 5 fever, and arthropod-borne viruses में भी हो सकता है, lymphadenopathy, beta-splenomegaly with lymphadenopathy, hemorrhagic manifestations if the condition is serious, dengue, hemorrhagic fever, chikungunya fever, meningococcemia, and multi-organ failures. जब हम, if these are not diagnosed and managed properly, they can end up with multi-organ failure and very serious outcomes. Amongst 1 to 2% of the patients, they in hospital setting, they present with drug eruption, and about 5 to 10% they present with the severe cutaneous drug eruption. Usually 3 or 4 are considered to be serious. Most important is Johnson syndrome and toxic epidermal necrolysis. This has high mortality. Even different studies, they quote different figures, 40 to 70%. Breast syndrome, drug reaction with eosinophilia and systemic involvement, and acute generalized xanthomatosis pustulosis. Various factors, they predispose to drug infections like genetic predisposition, hormones. It is said that male hormones, they protect against drug eruptions, and females are more prone to drug eruptions. Like जैसे ये autoimmune diseases नहीं होती, dermatologic diseases, they are more in females. Similarly, the females hormones, and they predispose to drug eruptions. An example of child with severe SJS, then you may say there is exfoliation, involvement of the eyes, skin is peeling off, there are purpuric lesions, vesicular rash, you can see here as well. Involvement of the lips, involvement of the eyes as well. This is case of Stevens-Johnson syndrome and toxic epidermal. There is a spectrum. On one end there is localized disease, erythema multiforme. On the other extreme there is toxic epidermal necrolysis. In between there is SJS, T, and overlap, and toxic epidermal necrolysis. This is a case of breast syndrome. Diffuse skin rash after taking antituberculous treatment. Pustular eruption, generalized non-erythematous base along with fever, acute generalized xanthomatosis pustular xanthomatosis. These three major severe cutaneous reaction due to drugs, different etiologies, and then when we have to diagnose, there are, this is scoring system for breast. It has also ijaz scoring system, and for drug causality, that is, if we have to determine the cause of causative drug in a severe cutaneous drug eruption, we have to use some scoring system. For STS, Naranjo score, or Eldon scoring system has been developed. This system, Naranjo, an American who developed this scoring system, can be used to diagnose this condition as well. For further diagnosis, patch testing can be done in all three, but oral challenge is not advisable in any of these. This is Naranjo adverse reaction probability score. There are 10 questions. It has to be scored. Scoring can be in minus as well. The score can vary from -4 to 13. The less the score is, there are less chances of cause-effect relationship, that drug is not causing that rash. If the score is more than 9, there is a definitive cause-effect relationship. If it is less, then it is doubtful, and in between there are probable and possible diagnosis of confusion. अच्छा, एक और सिस्टम हो सकता है, जैसे ये ग्रेडिंग बनाते हैं, इसको हम एक फिगर ड्रॉ कर लेते हैं कि कौन कौन सी ड्रग्स पेशेंट लेता है. फॉर एग्जांपल, ए पेशेंट हैज बीन टेकन फॉर months these ABC3 drugs. पेशेंट हमारे पास फीवर एंड रैश के पास आया तो हम ये देखेंगे कि विद इन लास्ट 7 to 10 days which drug he has taken. For example, this drug was taken for 2-3 days, बंद हो गई, तो this is unlikely to cause the drug rash. ये जो 3 ड्रग्स हैं जो महीनों से चल रहे हैं, these are also unlikely to be. तो हमने देखा कि रैश के निकलने के से पहले ये 2 ड्रग्स ली गई हैं, E and F. अच्छा, फिर हम उसका वो बैकग्राउंड देखते हैं. फॉर एग्जांपल, अगर इनमें से जैसे वी नो दैट सल्फोनामाइड इज अ कॉमन कॉज ऑफ ड्रग इरप्शन, तो हम ये सोचेंगे कि सल्फोनामाइड ज़्यादा लाइकली था. फिर हम उस पर अपना नरेंगो एल्गोरिथम लगा ले, एल्टन स्कोरिंग सिस्टम अप्लाई कर लेंगे. देयर आर 2 ड्रग्स व्हिच वर यूज्ड आफ्टर द ऑनसेट ऑफ रैश, तो दिस इज अनलाइकली कि रैश के बाद यूज हुई हैं, तो दीज आर नॉट द लाइकली कॉज. Investigations, common investigations, biochemistry profile, markers, inflammatory markers हम ये करते हैं. We can take from swabs for bacterial viral cultures, skin biopsy, skin tissue cultures, smear for giant cells. For example, if a patient we suspect that it's eczema hepatic, aspirate for PCR. Serology for bacteria, viruses, blood cultures, giant fluid aspirate, echocardiography if we think that the rash is of Kawasaki disease, coagulation screen in patients of Barbara. No management. Any rash, जो अगर देखेंगे तो that can fall in 3 groups. आपके पास patient emergency में आया, आपने देखा. If the patient suffering from जो severe illness के features हैं, shock के features हैं, ऑस्कल्टेट करते हैं, जी कोई चेस्ट इन्फेक्शन है, न्यूरोलॉजिकल साइंस है, तो दिस इज एन इमरजेंसी. इमीडिएट इंटरवेंशन इज रिक्वायर्ड. वी विल हॉस्पिटलाइज द पेशेंट एंड मल्टीडिसिप्लिनरी अप्रोच. इफ द पेशेंट नीड्स एडमिशन इन ICU, हेल्प ऑफ pediatrics, IU specialist, ICU specialist, and then neurologist, whatever the involvement might be. In certain cases there is clearly well-defined syndrome. जैसे हमें पता चल जाता है कि it is measles या वो है erythema infectious, patient is vitally stable, then patient can be sent home, can be managed at home with a regular follow-up. कि हम उसे patient के parents को बताएंगे if there are any symptoms जो भी red flag sign है, or if the patient develops that sign, for it they should come to the hospital. In majority of cases, diagnosis is not clear. We can keep the patient under observation. अगर हम here our role is कि if the जितनी हमने exercise की, उसकी age, morphology of the lesion, type of site of onset of the rash, spread, तो वो सारा हम apply करेंगे कि what is the potentially diagnosis. Idea is to differentiate whether the condition is benign or serious. Does it need hospitalization or can be managed at home? Life-threatening infections, fever and जिसमें meningococcemia, Rocky Mountain spotted fever. This is another ehrlichiosis, typhoid fever, viral hemorrhagic fevers, and acute endocarditis. They need immediate hospitalization, workup and empirical treatment. ऐसा नहीं है कि हम treatment का इंतजार करते रहेंगे investigations का कि जी ये investigation आए तो जैसे हम we think अपने उस हिसाब से कि the most probable diagnosis is this, we will start the antibiotics and the supportive. Now the summary is that whenever a patient with fever and rash presents, we have to obtain the thorough history, characterize the rash, किस type का rash है, associate assess for life threatening. वो हमने देखा कि अगर उसमें systemic signs हैं, immediately we have to go on that side. अगर patient vitally stable है, तो हम उसको उधर रखेंगे और उसका differential develop करेंगे कि क्या हो सकता है कि whether the cause is benign or certain tests if required, symptomatic treatment can be given. Thank you very much. If there are any comments and questions, Madam Selena will answer.
जैसा माशाल्लाह बहुत अच्छी मैं सिर्फ क्वेश्चन कह रहे हैं आपकी ऑब्जर्वेशन पूछना चाहूँगा कि समटाइम वी सी पेशेंट स्पेशली जो जुलाई अगस्त के महीने के बाद अक्टूबर नवंबर में आते हैं कुछ पेशेंट जो विद स्वेयर रैश ऑन द बॉडी उसमें जिस तरह मीजल का होता है कि स्टार्टिंग फ्रॉम उसका फेस से ऑनवर्ड जाता है वो सडनली ऑल ओवर द बॉडी with chest infection, with fever और sometime arthritis भी आता है। तो मैं अपने तौर पे यहाँ सब कोई पढ़ा के उसको पैरामीजल सिंड्रोम का नाम दें तो पैरामीजल तो जो रैश है वो रिलीव कर जाता है विदिन 7 days। तो आपकी ऑब्जर्वेशन या किस तरह का केसेस
जैसा आपने फरमाया सर कि जो जुलाई अगस्त ही क्या है वैसे ना कि दैट इज द पार्ट ऑफ देयर आर जब ये आर्थ्रोपोड बॉर्न इन्फेक्शंस डेंगू फीवर चिकनगुनिया वायरस ये हम जब तक सस्पेक्ट नहीं करेंगे वो नहीं। अब जैसे डेंगू का फीवर है इट कैन गिव राइज टू मोर्बिलिफॉर्म रैश इट कैन गिव राइज टू स्कारलेट फीवर जब फीवर जो वो कहते हैं कि सेटल डाउन हो जाता है तो ऐसे डिफ्यूज एरिथीमा और उसमें जैसे आइलैंड ऑफ नॉर्मल स्किन नहीं होते वो जैसे PRP में देखते हैं ऐसे एरिथीमा विद आइलैंड्स ऑफ नॉर्मल स्किन कैन बी सीन इन डेंगू फीवर। अच्छा ये हमारे जो बैंड में पेपर छपा उसमें कि कराची में जो चिकनगुनिया वायरस के बाद ऐसे मैकुलोपैपुलर इरप्शन देखिए दे हील विद डिसइंफेक्शन पोस्ट इन्फ्लेमेशन दे कैन बी ड्यू टू क्योंकि ये सारे वायरस जो है मॉस्किटो बर्न और बॉर्न वायरसेस हैं और ये उस मौसम में भी होते हैं perhaps might be seen in those patients क्योंकि हमारे तो अब चूँकि हमारे पास बाज़ दफ़े हम रिट्रोस्पेक्टिवली डायग्नोज कर सकते हैं से लाइक कि हम सीरोलॉजी कर लेंगे जो अच्छा जी रिसर्च की सीरोलॉजी या नहीं का तो चले जी आपने MS वन एंटीजन करा लिया चिकनगुनिया का टेस्ट करा लिया तो वो उसके बाद कर सकते हैं लेकिन जस्ट टू confirm the diagnosis.
Just a little addition in the list, because if we continue seeing these cases and keep in mind the atypical variety of Pediatric rosea, that also makes the bulk of these cases at times. Atypical Pediatric rosea.
नहीं वो असल में फीवर के साथ कम ही आएगा ना सर
Mostly after.
अच्छा सर ये अच्छा मैंने जब ये लेक्चर प्रिपेयर किया तो मैंने दर्मा के अलावा ये पीडियाट्रिक्स के बड़े तो कई वो जो उनके है ना फीवर विद रैश उसकी PRP तो PR का जैसे पीडियाट्रिक्स रोजिया तो उसका वो कहती है वो बच्चे या लॉन्ग लाइन्स वो सो बस जी वो फीवर वाले मैडम जी पीडियाट्रिशियन के पास तो बिकॉज ये भी हम देखते हैं ना कि जो PR है दैट इज लाइक herpes human herpes virus 6 HHV 7 and HHV 6
जैसे वो एपिलेप्सी के लिए वो प्रेग्निटॉल या कार्बोपेजिपिन ये तो से बहुत ज़्यादा एक्शन है आजकल फॉर डर्मेटोलॉजिस्ट में जो ऑब्जर्वेशन वो ये देखें कि जो एक नई मेडिसिन है नेमेटोलॉजी उससे बहुत ज़्यादा रिएक्शन आ रहे हैं उसी तरह के मल्टी फार्मिंग भी देखे और स्टीवन जॉनसन सिंड्रोम तो ये ज़रा ज़हन में रखिएगा ड्रग्स को इसके एपिलेप्सी का
एंटी एपिलेप्सी जो डिफ्यूज एरिथ्रोइडिस रैश विद इओसिनोफिलिया या उसके ग्रेन ये जो एंटीकन्वल्सेंट्स है यस मैडम मैं सर इतनी ज़्यादा चीज़ें थी
समंदर को वैसे ये बड़ा एक इम्पोर्टेंट टॉपिक है मैं देखता हूँ कि जब भी एस्थेटिक की कोई कॉन्फ्रेंस हो रही होती है तो हर एक धड़ाधड़ फोन निकाल के स्लाइडों की पिक्चर ले रहे होते हैं तो मैं नोट कर रहा था कि चंद लोगों ने फ़ोन निकाल के पिक्चर्स ली और हालांकि ये यूनिवर्सिटी क्वेश्चन भी है वाइवा क्वेश्चन भी है और डे टू डे प्रैक्टिस में एवरेज अगर आप आउटडोर में अगर देखें तो डेली आपको एक ना एक पेशेंट ऐसा ज़रूर आता है। तो ये जो हमने सारे लेक्चर्स इकट्ठे किए इस पर बड़ी सोच विचार की, वो केसेस जो हम डेली रूटीन में देखते हैं और वो वाले क्वेश्चन जो आप रेजिडेंट्स के एग्ज़ाम के लिए भी इम्पोर्टेंट। तो आप सब मैसेज करने के बजाय जो ही मौका मिले स्लाइड की तस्वीर ले लिया।